Thank you, Chairman. My name is Byung-Moon Kim from Severance Hospital in Seoul. My topic is endovascular treatment for ruptured, dissecting, and blister-like aneurysm. For ruptured, dissecting aneurysms, definite treatment for prevention of rebleeding must be given as soon as possible, because rebleeding of ruptured dissection may occur very early and resulting in severe morbidity, mostly death. The treatment method includes deconstructive and reconstructive treatment. Conventionally, reconstructive treatment includes proximal occlusion and internal coil trapping. In my experience and in the literature, internal coil trapping is the more reliable than proximal occlusion. This is the example. This ruptured dissecting aneurysm was treated with internal coil trapping. This is a coil mass. This type of internal coil trapping is usually immediately complete occlusion and reliably prevent from rebleeding. Furthermore, usually relatively easier than reconstructive treatment. However, it's not infrequent that complete trapping of the dissected segment is very difficult or even impossible. For example, major branch involvement such as pica or anterior coronary artery, poor collateral, for example, aplastic contralateral vertebral artery in the case of ruptured vertebral artery dissecting aneurysm, and poorly developed PCOM and ACOM in case of ruptured blood blister-like aneurysm. Finally, basilar artery involvement makes it impossible to occlude internal coil trapping. These are examples. This ruptured dissecting involved pica origin. This ruptured blood blister-like, and in this ruptured blood blister-like aneurysm, you can see anterior coronary artery arising nearby the ruptured segment. This is a ruptured basilar artery trunk dissecting, maybe blood blister-like aneurysm. In this case, deconstructive treatment, internal coil trapping, is very difficult or even impossible. This is another example. This chronic dissecting fusiform aneurysm ruptured. This may be rupture point. This is PCOM origin. This is anterior coronary artery origin. Unfortunately, compression test shows poorly developed ACOM and PCOM. So in this case, deconstructive treatment must lead to severe morbidity or maybe death. How to treat ruptured dissecting aneurysm which do not allow trapping? There are many reports about multiple overlapping stents with or without coiling. Recently, flow diverter treatment also increasing. This is an example. This ruptured left vertebral dissecting aneurysm involves left dominant pica origin. That time I treated this case with 2 overlapping stents alone with balloon expandable stent. At that time, self-expandable stent was not available. Delayed venous space shows contrast stagnation at the dissected aneurysm. 6 months follow-up control angiogram shows a remnant of small remnant of dissected aneurysm with the pica origin saved. This is left image is 18 months follow-up angiogram. You can see complete reconstruction of left vertebral artery with the saving of pica. This is another example. This case was treated with multiple overlapping stents with coiling. This is ruptured dissecting aneurysm. Pica origin is involved at here. This is jailed catheter. This is that uniform stand. Coiling is performed with the ballooning stand technique like this, with saving the pica origin. And finally, one more stand was deployed in the overlapping manner. This is final 3D reconstruction image. This is 6 months follow-up control angiogram. You can see complete reconstruction of left vertebral artery and saving of the pica. Recently, a systematic review and meta-analysis was published in the AJNR. In this report, deconstructive and reconstructive technique in the treatment of vertebral basilar dissecting aneurysm was compared. Immediate occlusion rate is lower, significantly lower in reconstructive treatment. However, perioperative morbidity is significantly lower in reconstructive treatment. Perioperative mortality, rebleed, recurrence, and long-term good outcome rate shows no remarkable interval change. Also, long-term occlusion rate shows no remarkable interval change. Also, in my report, this report about the recurrence after deconstructive or reconstructive treatment. In this report, a total of 119 vertebral basilar dissecting aneurysms were treated. 62 were treated with reconstructive treatment, including 1 to 3 stents with or without coils. 57 patients were treated with deconstructive treatment, mostly internal coil trapping. Recurrence rate was 13%. However, with no difference between reconstructive and deconstructive groups. Notably, pica involvement is the only predictor for recurrence. Furthermore, 3 stents with coiling method shows no recurrence. In this case includes 11 cases. This is, for example, here is a ruptured dissecting aneurysm, and pica origin arises from dissecting aneurysm sac. After proximal coil occlusion, this is lateral image. "11 days after treatment, rebleeding occurred, and patient died. That time, angiogram shows aggravation of dissecting aneurysm. I mean, enlargement of dissecting aneurysm. You can see pica origin here. Maybe retrograde flow through the dissecting aneurysm sac, friable dissecting aneurysm sac, into the pica might cause rupture. This is another example. Ruptured dissecting aneurysm here, and pica origin arises from here. 2 months follow-up angiogram shows recurrence, major recurrence. Fortunately, this is unruptured recurrence. Similarly, retrograde flow through the friable dissecting aneurysm sac through the friable dissecting aneurysm sac and into the pica caused recurrence. In 2014, Zhao et al. Reported about the predictor for recurrence after reconstructive treatment. Reconstructive treatment include stents with coiling. In their case, pica involvement, single stent use, and immediate partial occlusion are independent factors for recurrence. Now, let me show you my recent strategy. This is a ruptured dissecting aneurysm. Here may be rupture point, and pica origin is involved. This is a jailed microcatheter, and firstly, I deployed stent with jailing of microcatheter, and coiling was performed, and then 2 more stents were deployed in the overlapping manner. So this patient was treated with triple overlapping stent with coiling. This is the initial angiogram. This is rupture point. This is the post-immediate control angiogram. This is 10-day follow-up angiogram. 6 months follow-up angiogram shows a complete reconstruction of dissecting aneurysm sac, dissecting segment with the pica, with saving the pica. Now, from now on, I move to blood blister-like aneurysm. This is the first reported case worldwide in the Journal of Neurosurgery in 2007. This is ruptured blood blister, typical ruptured blood blister-like aneurysm. That time I treated this case similarly in the ruptured vertebral dissecting aneurysm. Initially, coiling was performed, ballooning stent technique, and another one additional stent was overlapped like this. This is a stent marker. 3 months follow-up angiogram shows complete occlusion state, and 6 months follow-up angiogram shows stable occlusion state. Notably, a gap is noted between coil mass and ICL lumen. This means neointima formation. Therefore, this ruptured blood blister-like aneurysm is completely excluded from circulation. This is another case. This is ruptured blood blister-like aneurysm. You can see anterior coronary artery here. This is jailed microcatheter. And firstly, similarly, I deployed Elvis stent partially at this portion. This is jailed microcatheter tip. This is a coil. At this point, I started coiling like this. Coiling started with the partial deployment of Elvis stent. You can see strum markers is crowding because that time I push the stent for axial compression. And then stent was completely deployed and microcatheter re-advanced through the stent like this. And more coiling was performed. Control angiogram showed near complete occlusion. A small remnant is noted. 2 more Elvis stent deployed with a similar technique like this. This is the third stent. This is a magnifying view. You can see crowding of stent strum markers. This is Flappana CT. You can see also. You can also see crowding of stent markers. This is initial image. 6 months follow-up control angiogram, complete reconstruction of structural IC segment and complete occlusion of blood blister-like aneurysm. This is basilar artery, blood blister-like aneurysm. Very similar technique. This is stent strut, jailed microcatheter. Coiling was performed, and then microcatheter re-advanced. 2 more stents were deployed like this. 9 days follow-up angiogram shows complete occlusion state. 30 months follow-up angiogram shows complete occlusion state. Also, you can see a gap between coil mass and basilar artery lumen, suggestive of complete neointima covering over the blood blister-like aneurysm neck. in my report, recurrence, in my report about the risk factor for blood blister-like aneurysm recurrence after reconstructive treatment. Reconstructive treatment include single to multiple stents, single to three stents with or without coiling. In this report, recurrence included 2 rebleeding cases, both cases deaths. Those 2 rebleeding cases were both initially treated with single stent assisted coiling, and rebleeding happened within 2 weeks, one at 3 days and one 10 days. Delayed recurrence, regardless of occurrence of rebleeding, did not happen after 2 months after treatment. Therefore, I recommend early angiographic follow-up is mandatory to detect recurrence before rebleeding after reconstructive treatment for blood blister-like aneurysm or ruptured dissecting aneurysm. This is another report published in last year in Chinese multi-center study. They treated blood blister-like aneurysm with a single stent, 2 stent, or triple stent with coiling. You can see hemorrhagic complication rate is very lower with increasing the stent number. Furthermore, recurrence rate shows very significantly lower in triple stent group. They showed using 2 or more stents seemed to result in a lower perioperative hemorrhage complication rate compared with the single stent group, and concluded overlapping 2 or more stents may provide higher obliteration rate, lower recurrence rate, and lower perioperative hemorrhage risk. This perioperative hemorrhage risk included rebleeding. So my primary treatment nowadays, my primary treatment method for the ruptured dissecting or blister-like aneurysm is multiple stents, if possible, 3 or more stents with coiling. I treated 31 cases with dissecting 3 or more stents with coiling. So far, there has been no rebleeding. However, if allowed, flow diverter treatment seems to be a better option nowadays because multiple stents with coiling may require technical demand. Now move on, flow diverter for ruptured dissecting of blood blister-like aneurysm. This dissecting vertebral aneurysm involves pica origin, pipeline insertion. This is images after pipeline insertion. 6 months follow-up control angiogram shows complete reconstruction, saving the pica origin. This is flap panel CT just after pipeline. This is 6 months after pipeline insertion. There are few case series, small case series about the flow diverter for treatment of ruptured dissecting aneurysm. The result of flow diverter for unruptured dissecting aneurysm has been very promising. For ruptured one, only 1 rebleeding has been documented in the literature so far. Because there are a few case series or case reports about flow diverter for ruptured dissecting aneurysm, the effectiveness of flow diverters for ruptured one should be further assessed. How about the result of flow diverter for blood blister-like aneurysm? In this review, meta-analysis, flow diverter shows a significantly higher long-term occlusion rate with a non-significantly higher complication rate. In this report, because non-flow diverter reconstruct group include single to multiple stents alone, single to multiple overlapping stents with coiling. So I guess it likely affected the higher retreatment rate and lower mid to long-term occlusion rate in non-flow diverter group. Single stent use is a significant predictor for recurrence in reconstructive treatment of BVA compared to multiple stents with coils. Finally, I shortly talk about treatment of recurrence. This is my recent report. Let me show you two cases. I go back to this case. This is ruptured chronic dissecting aneurysm. I treated this case triple overlapping stent with coiling like this. This is final control angiogram. 1 year follow-up angiogram shows recurrence like this. So I placed pipeline, two overlapping pipeline. This is 1 year follow-up angiogram. You can see complete reconstruction of the artery. This is very promising. This is another. This is the final case. This is traumatic dissecting aneurysm, ruptured traumatic dissecting aneurysm. This is CCF. This patient was treated outside the hospital with Elvis stent assist coiling. 2 weeks after the initial treatment, major recurrence occurred like this. So I put the pipeline. This is a follow-up control angiogram. You can see complete occlusion of ruptured traumatic dissecting aneurysm and decreased size of ACA. Left ACA is supplied from contralateral artery. In conclusion, if possible, the constructive method is a reliable treatment for ruptured dissecting and blister-like aneurysm. For the case that the constructive treatment is not feasible, multiple stents with coiling seems a good option. After multiple stents with coiling, early angiographic follow-up is mandatory for this type of treatment. My strategy is follow-up angiogram within 1 week, 2 weeks, second follow-up angiogram at 2 weeks, and third follow-up angiogram at 4 weeks after treatment. Third follow-up angiogram usually obtained before the 2 months. If allowed, flow diverter could be a good option because it may require less technical demand while showing similar effectiveness compared to multiple stents with coiling. Thank you for your attention.